Sorry. This is easier. Okay, select me. Hello, Jax. Hello.
Hello, I can hear you. But I was saying that your internet, you might be forced to go audio. It's giving you some problems.
Yes, yes. Can you hear me now? Or do you want me to go audio and then we can work from?
Yes. Yeah, let's try to go audio so at least we don't lose you. We don't keep on losing you.
Okay. So before we go audio, can everyone see that as a tourniquet?
Okay.
Yes, we can see.
Okay, so that's how the tourniquet is given. Hi, Jax. Yeah, I've gone audio now so that we can communicate and then you can share the screen.
Okay.
Is that okay?
Okay.
Hopefully this is better. So like I was saying before, we are having issues with our network from this end. It's been raining a lot. And every time it rains, it affects the network. So apologies for that. We did a testing and it was fine. And then when it started raining, this happened. I was talking about cat tourniquet. I tried to show it, but because of the video, the streaming problem, we're having a problem. So I'm just going to recap where we are. So we started with the big C. So we stopped the big bleed, the catastrophic bleeding. So that was given by Justin. Then we went to airways. Jakes gave the lesson last week on Wednesday. We say the importance of obviously making sure the airway is clear, it's open, and it's patent. And now we are going to speak about so we are now on breathing.
Okay.
Yeah, go to the names, the aims.
Oh, give me a minute. Okay.
So as you can see there, so our main aims or my main aims today is trying to convey you as a participant the knowledge and skills required by a layman.
Wow.
Can you see the aims?
Yeah.
So yeah, we try to relay the message to a person who is not medical. They might, so that in case they encounter emergency at school, work, or at home, they'll have the knowledge and skills to deal with it. Okay. So the next slide. So our objectives. So we are trying to achieve, we show you how to protect life, how to prevent worsening of condition, and how to promote an ease of recovery. So when somebody goes unconscious, whether that be they're going under cardiac arrest, we want to restore life, and we want to prevent that condition from getting worse. Because remember, when the heart stops pumping, it means you're not getting enough blood or oxygen supplying your organs, and the organs will start dying. So the longer we stay without oxygen, the longer or the worse the injuries becomes. So that's why we're trying to achieve, we protect life, we prevent a worsening of condition, and we promote an ease of recovery. Next slide, please. Next slide, Jex.
Yeah, it's there. You can see it.
Yeah. I've seen it now. Yeah. So the general concept of the basic life support, I'm just going to give you, like I've just said there. So we rely on the heart to make sure that our blood takes in, our blood is circulated, and so that we can get oxygen and release carbon dioxide. So the blood is then returned to the heart, where it's pumped out to the organs, and including the heart and the brain, as well as the rest of the body. When the heart stops, so this system stops, and without blood flow, the heart and the brain will quickly become damaged due to the lack of oxygen. So for us giving this BLS, basic life support, it improves a person's chance of survival until advanced care becomes available, or until a medic or someone who is professional trained comes and takes over. Next slide. So the importance of a bystander, the importance of somebody who thinks they are not medical, especially in the community response to cardiac arrest, it's critical in saving lives. Many deaths occur because patient has not received a bystander CPR. So CPR is cardiac pulmonary resuscitation. And by the time the emergency service is arrived, the person has died. So strengthening the community response to cardiac arrest and training and empowering more bystanders to perform CPR increases the use, and increasing the use of the defib. I'm going to explain about the defib briefly. It could save thousands of lives each year. So we're trying to empower you as a non-medic person, so that when you encounter or when you see someone is not breathing, at least you know how to afford them some help. Next slide. So this is called the chain of survival, and it shows how one thing depends on the other so that someone can survive. So the first thing in the chain of survival is early recognition that somebody needs help. So you see someone unconscious or they're not breathing, and like we are very fond of doing, we start taking pictures, we take too long, we're not quite sure. You need to go there and make sure if this person is not moving, are they just not moving because they're unconscious and breathing, or are they just unconscious and not breathing? So the quicker you go there, the quicker you start talking to these people or this person, the quicker you realize actually this person has stopped breathing. So you prevent the cardiac arrest. Once you know they're not breathing, then you need to go to the next phase, which is cardiopulmonary resuscitation, which is CPR. And the reason you're doing that, you're trying to buy time, and I will explain that in the later slides. Then you do early defibrillation. So what is happening, especially in the developed world, they've made these defibrillators, or a shock pack, if you may. They've made them available in every shopping center, every shopping mall, where people gather, maybe in the football stadiums, so that when somebody is not breathing, you can try and restart the heart. Then once you've managed, or if you're lucky enough to restart the heart, you need to preserve that life. So you are restoring the quality of life. So if someone has come back again, if the heart has restarted, they still have higher chances of the heart going stopping again. So you don't want to just think about it like someone has just done a marathon. After a marathon, when they've just trying to recover, then you're telling them to go run another marathon. So that is how you're supposed to see when someone has just come back from a cardiac arrest. So the body was in turmoil. So when they come back around, especially the brains were deprived from oxygen. So they are still in that drowsy state. And the heart, again, it wasn't pumping. So there was not enough oxygen on the muscles and the organs. So when they come back alive, there are some few things that we normally do to make sure you are not actually aggravating or making the situation even worse. Next slide.
Tirus, you there? Did he drop?
Yeah, can you hear me now?
Yeah.
Yeah, I was just going to talk about the precordial thumb. So in the developing world, where we don't have these machines or the shock pack readily available, this has been tested and it's something that can actually buy you time. So what you're trying to do, like I said, so a precordial thumb, what you're trying to do, you're trying to shock or you're trying to emulate what the life pack does. So you want to have your fist and hit the sternum of the person that is not breathing. And the intent here is to interrupt the potentially life-threatening rhythm. The thumb is thought to produce an electrical depolarization of 2 to 5 joules. So whatever you're trying to do to achieve here, it's very, very small, but it's better than none the rest. So when you have a shock pack, it will deliver 200 joules, which you also get. Obviously the minimum of the joules required is about 200. So you can see it's quite small, but it's something better than doing nothing. Precordial thumb is recommended for witness arrest when you are walking or when you just see someone collapsing, when they just had or they're experiencing the cardiac arrest. And it's recommended when the defibrillator is not immediately available. Next slide. So that's the basic life support algorithm. So what you want to do, and I'll explain it in details in the later slides. So you can see them, someone is unresponsive, they're not breathing normally. You need to call for help, ask somebody to call ambulance or ask somebody to come and help. Then you start doing something called CPR. So you'll be doing 30 chest compressions and 2 rescue breaths. I've explained it again on the later slide. So this is just a quick snapshot of this procedure of the CPR. And you want to do this at the rate of 100 and 120 chest compressions per minute. And you continue doing this until obviously it helps our lives or you get someone to relieve you. It's also advisable when you have someone next to you or bystander, try and swap it after every 2 minutes to prevent fatigue. So next slide. So again, when you're going to this person, obviously you don't know what has made them go to cardiac arrest. So your safety is paramount. So it's your safety first and the person's safety. So be safe. When you're going there, don't just run and get tunnel vision. Make sure maybe they haven't been electrocuted or anything, or if they're in the middle of the road, move the person out of the traffic. If they've been electrocuted, don't go and use your bare hands. Use a rod or something, or not a rod. Use a wooden plank, something that you know it's not going to conduct electricity. Or if they've been drowning, if they've fallen out in the river or lake, obviously don't dive in. Make sure you are careful and your safety is paramount, like I've said there. And make sure you don't get injury or don't get injured yourself. Assess the person. So we've gone through the assessment. You're trying to shout, you're trying to talk to them, you're trying to shake them, and you're talking to them very loud. There's also other bits you can use. You can use a painful stimulus, so you can pinch the earlobe, so that you're trying to see if they are going to whinge or they are going to move, because sometimes people sleep and they sleep very loud or they're in a deep sleep. So you want to pinch them and see if they're moving. Check to see if the person is breathing. And again, there's something called agno breathing there. Agno breathing is when somebody the heart is not pumping. It's like, the way to emulate it, like someone has died or someone has chokings, and it's not regular. So if you see someone doing agno breathing, don't confuse that with breathing. And it's occasional gasping and it's ineffective. and this does not count as breathing. Again, you want to call 999 or 911, depending on where you are. Send someone for help, and if you are in a place you know you can get the shock pack, the IED, the defibrillator, ask them to go and get it. If you are alone, you want to assess for breathing for 5 seconds, but no more than 10 seconds. You do not need to take, you don't want to take more than 10 seconds checking if somebody is not breathing. If you're not quite sure, assume they are not breathing, and you start the CPR. When you're doing that, when you're assessing for breathing, you also need to check for the pulse. The quickest way, because you're checking and you're feeling through on their nostrils, you want to check the pulse on the carotid pulse, on the neck area. Unfortunately, I'm on audio, otherwise I could have shown you where you need to check for the pulse, but it's on by the side of your neck. You'll be able to feel the pounding pulse, and that's a carotid pulse. Check for the pulse. Begin, if there's no pulse, begin compression and deliver the 2 rescue breaths. When the defibrillator arrives, attach the defib. I'll show you on the next slides how to attach it. And the machine is straightforward. It will tell you, it walks you through how to operate it. So it doesn't matter if you've ever seen it or you have never seen it, just follow the pictures and the prompt. Next slide. Yeah, so that's the basic support. That's the hand positioning. So you want to go in the middle of the chest, on the sternum, on the lower end of the sternum. Use one palm, and then you interlock your other palm. Lock your elbows so that all your weight from the shoulders is going directly to the person. And you... So this is quite painful. Someone here is not breathing. Someone, the heart is not pumping. So what you're trying to do, it's like you are trying to do what the heart was doing. So you are trying to reach the heart through the sternum and try to squeeze it. So imagine or assume you have the sternum, you have the ribs, and then the heart is inside there. So what you're trying to do with that force is try to squeeze through the ribs over the sternum to get to the heart and try to squeeze it so that you can try and circulate the blood across the body. On the other slide on the right, you can see how you place the pads. Those are the 2 pads you place on the person's body. Next slide. So that's the theory. After each compression, release all the pressure on the chest. Again, you want a proper full recoil, because like we said, you are trying to reach the heart, you are trying to squeeze the heart through the ribs and the sternum. So if you press and you don't release it, again, you haven't achieved your goal. You haven't managed to squeeze that heart, and you haven't managed to get the impact you're after. So you want to do this without losing contact between your hand and the sternum, and this results in a better venous return. So you're doing that, and like I said, you lock your elbows, you make sure all your weight is coming from your shoulders all the way to the palm of the hand. For those medics in the house, those people who've done it, I can see we have Frank there, and I know other people, Jakes, have done it. It's tiring. So by the time you're doing that, in 2 minutes, you won't swap over because your arms, your shoulders will be burning. The next slide. So like I said, I said in the narrator said, this is how now I've tried to explain the procedure. So check for the carotid pulse. Again, you are checking that on the neck area. Feel for 5, but no more than 10 seconds. If you're not sure you can feel the pulse, begin CPR. It's better to do CPR than not. Begin CPR with a cycle of 30 chest compression and 2 breaths. So this is for the adults, and I'll probably, coming to the end of the slide, I will discuss briefly for the slight change for the children and infants. But for adults, you want to do 30 chest compressions at a rate of 100 and 120 compressions per minute. You do that on the depth of 5 to 6 centimeters into the person's chest until for 2 minutes. Put your, like I said, put your other hand on top of the first hand, and be sure that between each compression, you completely stop pressing on the chest and allow the chest wall to return to its natural position. And that is a full recoil. Next slide.
Tirus, I beg to interrupt. There's a question.
Yes, sir.
In the chat.
Yeah.
Amolo is asking, how do you call this type of CPR techniques?
How do you what, sorry?
How do you call this type of CPR techniques?
Oh, this is, well, I'm not quite sure. I don't know if I understand the question, but that the technique you are doing, this is called cardiopulmonary resuscitation. I don't know if I've managed to answer the question. We'll come back to the question. If maybe the question can be worded differently.
Okay, Amolo, if you are listening, please, you can word it differently so that you can get an answer from Tirus. Please proceed.
Yeah, so after 30 chest compression, stop compression and open the airway by head tilt chin lift. This is the last one we did last time, because when somebody goes unconscious, the natural position gets compromised. So you want to make sure when you're giving these 2 rescue breaths, you have a good access on the airway, and the tongue hasn't fallen back, or the natural curve of the trachea hasn't collapsed. So you do the head tilt chin lift. So put your hand on the person's forehead and tilt the head back. Lift the person's jaw by pressing your hand, index finger, and middle finger on the lower jaw and lift. The only exception for this is when you suspect a neck injury, so you don't want to make it worse. So you go for something called jaw thrust. And this is when you grasp the angles of the lower jaw and lift it with both hands, one on each side, moving the jaw forward. Again, you're trying to gain access to the airway. If the lips are crossed, open the lower lips using your thumb. So give a breath while watching the chest rise. So obviously you want to make sure that the breath that you've given, it's gone all the way to the lungs. And for you to know this, you'll be able to see the chest rising up and falling. Repeat while giving a second breath. Breath should be delivered over 1 second. So you're giving 2 breaths, so that will be 2 seconds. And then you want to resume chest compression quickly. Switch quickly between compressions and rescue breath to minimize interruptions in the chest compression. Remember, what we're trying to emulate here is what the heart does. So the heart is pumping, it squeezes the blood so that it can go around the body, and this is what you're trying to do. But the fact that we are stopping over to give the oxygen, you don't want to take too long there, because again, you are not going to achieve what our main aim here. Next slide. Yeah, next slide. Next slide, Jakes. Yeah, so that's just a quick snapshot of the stuff I've just spoken about. So if you got somebody and they're not breathing, again, you want to start the CPR straight away, and you do this 30 chest compression to 2 rescue breaths. Continue doing this until help arrives, or somebody comes and gives you the shock pack or the defib. We know I call it IAD, automated electronic device. So it works like it's automatic. So once you put the two pads on, it will tell you what to do. Next slide. Next slide. Okay, yeah. So these are called the reversible causes of cardiac arrest. When somebody has stopped breathing, when someone has gone on a cardiac arrest, they are the things that you want to consider. They are the things that you want to eliminate, because these are fixable. If you fix them, there's higher chances of somebody coming back around. So the first 4H, the first H is hypoxia. So this is when somebody has been deprived of oxygen. So that be it, someone is choking. For example, for those people who are drunk, or they've taken 1-2 minutes and they vomited, that could cause hypoxia. So if you came to somebody who has stuff, or they have fluids in their mouth, again, it means the oxygen is not going through. So you want to remove that. So hypoxia is the first one. It means the oxygen is not being delivered. Another one we've already spoken about is hypovolemia. This normally happens when there's a tap open. And when I say a tap open, your blood circulation is a closed circuit. So when there's a small hole whereby you're losing blood, you can continue doing that until there will be nothing for the heart to pump around your body. So you want to close these taps, and that one can be fixed. So if you went to somebody and they've lost a leg, before you even start doing the CPR, or when you're doing the CPR and you see that there's some blood seeping out somewhere, get that tap closed. The next one is hypothermia. Again, when it's very, very cold, everything seems to freeze and seize. And this is very evident, especially for people who live overseas. And for the case of myself in the army, I've gone on an exercise and it's minus something. Everything seems to take forever, especially with your hands. Your brain is still telling you what to do, but everything is so slow. So the same thing happens. If the temperature has gone under even 30 degrees Celsius, if you may, everything stops. So if you got somebody and they're very, very cold, they are dead cold, you try to warm them up. And the way you do that, maybe you put a blanket on, or you do something called body. You try to hug them, because you're trying to pass your body heat to them. So that can be reversed. Another H is hyper or hypokalemia. Hypokalemia is more of like a potassium levels. There's nothing you can do on the hyperkalemia, but you can do hypoglycemia, especially for people who suffer from diabetes. When their sugar levels goes down so low, that could cause cardiac arrest. You want to give them a quick sugar so that they can, some of them they normally carry their glucagon injection. So whatever they carry, if you see someone is, and there are sometimes the symptoms of hypoglycemia, they seem like they're almost drunk, but they're not drunk. So if you suspect something like this, try to give them some sugary drink. That can be fixed again. That's why we say there's 4H and 4 T's. On the T's, the first one is toxins. Toxins, that could be those people who are injecting or maybe taking class A drugs. That it could be that, or poisoning. So if someone has taken poison and they still have some element of it in their mouth, you want to remove that on their system. Cardiac tamponade is when the myocardium of the heart, when there is that membrane, it's filled with, when it's, for example, there's an infection and the muscles of the heart, the membrane itself starts to have a buildup of fluids. So it stops the heart from squeezing, doing the working properly. That can be fixed. Obviously, that needs to be done in the theater. So the doctors will put a needle in and they will pierce through the myocardium so that they can relieve that fluid. Tension pneumothorax. So again, this is when someone has had a penetrating chest injury. For example, they've had an accident, they've got trauma in the chest, and that chest cavity, it's filling up with either air or it's filling up with blood. Again, remember, we want the muscles, we want the heart to do the work. We want it to pump, to do the squeezing movement. So if that state it's filled up with something else, it will stop it from, or it will restrict it from doing its work properly. Again, for the medic in the house, you can do needle thoracentesis or chest drain. So that's for the trained people. That's why it's one of the T's. And another one is thrombosis, and this is a clot. So if there's a clot in your system and then on the artery, and it has gone through and it's stopping blood from going further an organ. So obviously, where the clot stops, everything over and above, that it's not getting enough oxygen, or it's not getting enough blood supply, and therefore there's not enough oxygen. For the medics, doctors, paramedics, we normally give GTNs because GTN will dilate the vessels or the blood, the arteries, so that the blood can go through. We can give aspirin, so the aspirin will thin the blood, so that hopefully we try and make the blood thinner so that it can seep through. Or when they go to the theater and they get a stent, that clot it's blown off. So that's why we have the 4H and 4Ts. Those are the reversible. So if you can reverse those things, you can restore somebody's, someone can come back alive. Next slide. So this is for the advanced life support. I'm not gonna go into this because obviously I really appreciate majority of people here, they are not medics. But this is just to show what the doctors, the medics who are trained to do the stuff they can do. So there are two types of shock algorithms. So when you put this defib or the machine, it will tell you that if the rhythm, once it goes through the rhythm check, it will tell you if whatever the person is suffering from, if it's something that they can be shocked, or the heart can be restarted, or whatever they are suffering, the heart cannot be restarted. So we normally have shockable and non-shockable rhythms, and that is ventricular fibrillation and post-rate ventricular tachycardia. So those ones, the defib or the shock part can restart the heart, and the heart will go back to its normal rhythm. On the other hand, we have pulseless electrical conductivity, that is PA and asystole. Again, those are something I said I don't want to insult people's intelligence here, but people will understand when they see that. And I've also shown about the shocks. So you obviously want to do shock within the fact that what they say there for on the shocks, you want to minimize the interruption. So once the defib has gone through its rhythm check after every 2 minutes, it will tell you if it needs to shock the person or not, and then you carry on from there. So next slide. Yeah, so those are the special considerations. And the one I wanted to stress on is hypothermia. And like I've touched it before, I've said when your blood temperature goes very, very low, it starts to affect even the way the body operates. So when you go under the 30 degrees Celsius, even the medication will take longer to take effect. So a more thorough assessment of the breathing and circulatory, I'm assuming the circulatory system will be the next topic next week or next Wednesday. So a more thorough breathing and the circulation bit, it needs to be taken when somebody has gone to hypothermia. So the way we normally do it in the army or in the medics down here, we have mnemonics called rise and fall, and I'll just quickly take you through that. So when when you do a breathing assessment, so you want to check their rate. So you want to see are they breathing normally? Are they breathing too fast, or are they breathing so low? So is the breathing normal or abnormal? Then you want to see if they have any visual, any physical injuries you can see around the chest. Again, so you need to do this when you've exposed the chest. So when you go to the chest and you can see maybe they've had an impact, and then you can see an indentation of one of the ribs. Again, you start to realize there's injuries on the chest cavity. Again, you want to see if the chest is rising and falling in a symmetrical way, in an equal way. So if one side of the chest is rising and the other one is still intact, then obviously you identify that and you know something is wrong internally. And are they making any effort in breathing? Are they actually struggling to breathe? Are they actually maybe exhausted? They don't even want to breathe, or what is their effort in breathing? And then the N, like I said, is right and fall. So on the N, that is a neck. And the mnemonic we normally use is 12. So You're checking for the trachea. So the trachea is a windpipe, around the windpipe here, that on the Adam's apple. We used to call it Adam's apple. So that kind of once you get to the other Adam's apple, you go to the to the notch there on the hole. That's where the trachea is. You want to feel if it's central. If you see it being pushed to one side, those are the later signs of something bad happening around the chest cavity. You want to check if there's any wounds around the neck area. If you can see any wounds around the neck area, again, how deep are they? Are they anything to worry about, or are they just a small scratch? On the again, like I said, on the neck area, you want to see if there's any emphysema. Is the air seeping out through the membrane, or is it coming out through the muscles? Can you see something called Rice Krispie? Can you see like bubbles? You know, like the bubble wrap, the way you see a bubble wrap, like small pockets of air trapped in a bag. Can you see anything like that on the, especially on the trapezius and the collar, bone collar area? Can you see anything? We call it emphysema there. How about the larynx? Is it mangled up? Have they received an impact on the neck area? Is it still, can they hold itself, or is it just collapsing every time you're touching it? What about the neck veins? Are they distended? Is it like they've been tight? Like if you put a tight band around your arm, the veins around after where you put the tight band, they become distended, because it means they're not, the blood is not going back. And every time, obviously, you check the neck, and if you suspect the neck, if you're suspecting any spinal injury, make sure you secure the neck, or you don't move the patient, so you prevent movements of the neck area. Next slide. So the next slide, it's I spoke about drugs. So, and I said there will be less likely, or there are less effective. Yeah, drugs. So when the temperatures go down, everything, it's like if you put something on the freezer, it takes longer to obviously to go off. This is the same thing that happens when you go down on the hypothermia. So for the medics, again, you are advised to give adrenaline with caution, and everything you double the time. So instead of doing every 3 to 5 minutes, you double that time. And again, hypothermic heart may be unresponsive to cardioactive drugs. So, and this can become toxic. Next slide. Yeah. So if you manage to do this, and you manage to bring that person back, the first thing if someone wasn't breathing and you continue doing the CPR, when they come back around, the first thing they'll do is try to push you away, because like I said, it's not the best thing to do to somebody. They will feel pain. So when you see somebody fighting you, it's an indication of maybe someone has come back alive. So they're probably breathing on themselves. Again, I gave an analogy, and I said, when somebody is come back alive or come back around, imagine someone having finished a marathon. They've done 28 miles, and you don't want to keep them or to give them another run. So when they come back alive, take them gently. And again, for the medics in the house, you need to monitor the vital signs, check their ECG, the waveform capnography, that is the CO2 output. You want it to be between 4.6 to 6.0 kPa. You measure their BM. Again, if it was hypoglycemia, you want to know how much blood sugars or blood glucose in their blood glucose and temperature. You measure the temperature as well. And again, like I said, keep the reversible causes. Keep going through them. Keep going through the 4Ts and 4H and 4Ts. As you take this person to the hospital, to A&E or emergency department. And again, constantly assessment of the above every 30 seconds, every half a minute, keep going through it, because coming back around, it doesn't mean they cannot. They are actually on higher risk of going back to cardiac arrest again. Next slide. So again, when you're transporting these people, the casualty, make sure you transport them when they are lying flat, especially for the because their brains have been deprived from oxygen. The little oxygen they are getting now, you don't want to sit them up, and then because of that postural drainage, the brains will go back. They will become hypoxic again. So you want them to lay flat, and any movement you do, be very, very gentle. And ultimately, always be prepared to recommend CPR, as the likelihood of the patient returning into cardiac arrest is relatively very high. So basic life support in children, and I'm talking about in the age of between 1 and 8 years. If you have 2 people, then you have the time that we said about 30 chest compressions to 2 rescue breaths. So you have this, you do 15 to 2. But if you're on your own, again, you do the 30 to 2. You can, again, you don't have to use the 2 hands. You can use one palm of the hand, because remember, the children are quite malleable and they are only tiny. So you don't want to go with both of your fists. You can use one, or you can use the 2 fingers and you want to get a third of the chest. Remember, we said for the adults it's 5 to 6 centimeters, but for children you want to do third of the compress the chest, at least 1/3 of the depth of the chest. In children, mostly in children, the primary cardiac events are not common, but when they do happen, it's normally because of oxygen or because of their airway. It's preceded by respiratory problems. So survival rates improve with early intervention. So the moment you intervene, whatever is happening, the survival rate increases. Remember, prevention is the first link in pediatric chain of survival. So you want to prevent this from happening. So a lot of kids, obviously, because they are quite, especially when they're quite young, they can even sleep funny, or they compromise their airway when they sleep. So one of the causes of cardiac arrest could be because of how they slept. Next slide. So that's a screenshot of algorithm for the kids, 1 to 2, between the age of 1 to 8. So you want to check if they are breathing. If they're not breathing, obviously check within 5 to 10 seconds, no more than 10 seconds, and begin the cycle of 30 chest compression to 2. But then it's advisable, if you are 2 rescuers, you do 15 chest compression and 2 rescue breaths until the IAD. And the beauty with kids, because they're only small, you can do this on the move. So that is CPR and in BLS and CPR in a nutshell. Have we got any questions in the house? Hello, Jex?
Hello, I can hear you.
Yes, I think that's BLS CPR in a nutshell.
Okay. And then
If you see it.
Yeah, so
questions?
Yeah, so let me show them a video here.
Yeah, or adults suddenly.
Yeah, just to summarize what you have just said.
Yes,
let me
sir.
see. Okay.
If you see a teen or adult suddenly collapse, it's important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to send someone to call your local emergency response number or call it yourself. Then get directly over the victim. Put the heel of one hand in the center of the chest. Then put your other hand on top of the first. Then push hard and fast in the center of the chest until help arrives. It's important to push, giving 100 to 120 compressions per minute, which is about the same tempo as this song. Let's hope you never have to use hands-only CPR. But if you see a teen or adult suddenly collapse, don't be afraid to try it. Remember, call your local emergency number, then push hard and fast in the center of the chest until help arrives. Your actions can help save a life. To learn more, visit international.heart.org.
Okay, so that's how it is done. And as Tyler said, it should be at least 30 compressions in a rate of 100 beats per minute. And you don't forget about those two rescue breaths. If you are two of you, you can just designate one person to be at the head, and then you can be doing the CPR. So once you start the CPR, maybe you can be interchanging around between you guys, but you cannot stop until the next echelon of care arrives. So Tirus, you have something more?
Yes, sir.
Okay.
Yes. You guys can see me now, isn't it?
Yes. Yes.
Okay. So what I'm going to do, I'm just going to turn the camera ever so slightly so that I can show you how the defib looks like. In fact, I think it's much easier to maybe bring it here. Can you see her?
Yes.
So I went to work and I got this for guys so that they can just have a quick look and see what we are talking about.
Analyzing heart. Do not touch the patient.
So
No shock advised.
So this is a shock pack. So
if needed, begin CPR.
okay. So it normally does that. So this is not just a life pack itself. It's a heart monitor. It's a life pack. It comes with a defibrillator inside, and it does everything else, like I said. So I've just put it on automatic or automated electronic device. So if I wanted to have a normal monitor, I'll just switch that, and it will give me everything, and I will be able to see the blood pressure. I can even do the electrocardiography. It does a lot, but this is because I couldn't find just the shock pack on its own. I decided obviously I should bring something so that people can have an idea of what you're talking about. So,
Analyzing.
So if I was to shock somebody,
do not touch the patient.
That's the prompt you get. So once you put the pad,
No shock advised.
it will tell you that. So if you had said that,
begin CPR.
right? Okay. So if you are told shock advised, you need to charge it. Obviously, you select the jaws. Then you need to charge it. Let's have a look. So let's go to 200 joules. So you're charging it, and you can see there. So that's 200 joules, and it's telling you to shock and shock now. So that is a shock of 200 joules that has been delivered. Again, because I'm doing I'm not putting any pads. This is how we test it. This is the shock. This is the one that takes the shock. So if I had my tongue there or my finger, I'll probably be dead by now, because that is 200 joules worth of shock. And if you check the YouTube and stuff, you'll be able to see what the shock does to people when they are shocked. It jumps them from where they are sat. So on the Celox, on the catastrophic bleeding, remember when you said about stopping the tap, you need something like this. If you're on your own, self-aid, I know I'm repeating stuff we've already spoken about. It goes through the roof, put it in. So assuming I've lost my limb there, put it in, put the Velcro in, and this is where the fan is, twisting this rod. And even just doing that on its own, it's very, very painful. So you want to twist it and twist it until it stops. And then you lock it into place and tie the loose end. Obviously, you don't want this to be flapping around. Tie the loose end and then put the time there. So I know we spoke about that, but I just wanted to show you the stuff that you use to stop the bleeding or to fill in the holes. This is called Celox. This is not a training, this is actually a real one. We use that when you go on operations. I'm just going to open one and I'll show you how it looks like. You want to pack this in a wound. It's made out of seashells or sea fish product, and it acts with the body heat. The moment it's activated by the body heat or the blood, it will start making the blood clot. So you open it. I'm opening it because obviously it's expired, but it's still useful. And that's how it comes like. So you want to open it, and you'll be rolling this straight to the wound. If you're packing the wound, you want to roll it and pack it, push it, keep pushing it until you see the hole has been completely filled. Then take a bandage. I have a bandage here. This is a bandage. It's called emergency bandage. I don't know if everyone can see that. So again, it comes compressed, obviously, because of the space, but I'm just going to open it. Again, it's expired. That's why I'm opening it for training purposes. So it's actually compressed there, but once you open it, and it's sterile as well. So you pack that. So when you're packing the wound, when you have if you have someone else, you want to be asking them to open it and prepare this. So you want to open it, and once you get the wound packed, this part here, you put it on the direct on the wound, and you put pressure there for 3 to 5 minutes until the bleeding stops. So a good indication, the way we normally do it, is you have this, and you obviously you cover the wound. If the blood seeps through and you can see the blood seeping through, it means you probably need to put more package. You need to package it more. You keep doing that, you can put another bandage until the bleeding stops. Again, as you can see here, it's elastic. So that elastic effect, well, the moment you continue doing it, it's providing the tourniquet effect. Obviously, it's compressing even the inside, the arteries that you can't see on a physical eye, the internal injuries. So that's Jake. Unless you have anything else, I think that is it for today. And unless anybody has anything to say or to ask.
Hello, Tirus. We have a question from the chat.
Yeah.
Again, it's a Molo asking, is there any guidelines, recommendations for defibrillation of hypothermic patients? For example, patients with severe accidental hypothermia.
Okay. So in UK, we normally use something called resus This has guidelines. Let me just quickly tell them what they normally say. So Resuscitation Council 2015, we normally go by that guidance. The last time of the Resuscitation Council, for when it comes for hypothermia, we go with the guide of if somebody has gone, or if you measure their temperature is under 30 degrees Celsius, you need to have, or you need to double the time where you're doing the medication. So the only thing you need to do, I think it was on just give me a second. There's some consideration when it comes to shocking when someone has been submerged or someone has gone on hypothermic. Right, yeah, so a quick one, and it's on the slide here. So defibrillation is less likely to be effective at lower body temperature of less than 30 degrees. If VF, obviously when you put the pads and it tells you to shock, so when it tells you to shock, it's either someone is in VF or PVT, so posterior ventricular tachycardia. So if you shock and you've already done 3 shocks and it's still, the machine is still going through and it's telling you to shock again, delay further defibrillation until the core temperature is above 30 degrees. Because it means whatever you're doing is being slow, because someone has gone so low and everything has slowed down. You don't want to continue shocking and you make the case worse. So yes, there's some consideration when somebody has gone hypothermic of less than 30 degrees of the core body temperature less than 30. You want to restrict shocks to 3 until maybe you try to rewarm the person and the temperature rises, the core body temperature rises over 30. Okay.
So Tirus.
Yes, sir.
Yeah. So also to add whatever Tirus has said, for those patients that are less than 30 degrees, the best thing you can do is you cannot just stand by and just watch them. So the best thing you can be doing as you are rewarming them, you can be doing CPR. But defibrillation won't work because they're already very cold. Their core body temperature dropped below 30, so they cannot react to anything. So, and also another thing you can do, hypothermia is one of the things that can be prevented. And the people in the military, we all know that hypothermia kills a lot of people in the battlefield, and is one of the easiest things we can prevent. And we prevent it by just rewarming the patient, covering with blankets, changing the wet clothes, and putting them in a warm, fuzzy place. So when you are doing that, do CPR as you are waiting for them to defibrillate later.
Yes, sir.
So anybody else? Any other questions?
Any other questions? Yeah. Thank you. Was it Amondi for the question?
Amolo.
Amolo. Thank you, Amolo, for the question. I think you've asked another question. Can somebody check? Because
she has asked two other questions.
Yeah.
So the first one is, what about giving adrenaline? And then the next one is, what type of warming techniques can be used?
Okay, so for the administer of adrenaline, whether that is IV or IO, you want to give adrenaline but double the interval time. Like I said, you normally give adrenaline every 3 to 5 minutes after the 3rd shock. So for the normal one, you give adrenaline at the 3rd shock, the 5th, the 7th, and so on and so forth. For this one, after the 3rd shock, you give adrenaline, then you give on the 7th, then you give on the 11th. So you are prolonging the time. Instead of every 3 to 5 minutes, you want to double that time. So, and again, for the techniques for warming the patient, the first one you do is body. Just, it's called skin to skin. If you know this person, if you know the person, skin to skin works. So if you, for example, if you go there and you hug the person, it means your body temperature is being transferred to this person straight away. Or you use something called breather blanket. I've got a blanket, I'll show you quickly. So this is what we normally have. It's called blizzard blanket, blizzard heated blanket. So I'm not going to open it because the moment you open it and you activate the air, it has the bead that gets activated and they'll start to heat up when they mix with oxygen. So it's actually, these are full blankets only because it's been compressed and it fits to this in the palm of my hand. But if you are medic and you can see there, it's actually covering a person. So if I was on the ground and someone has got a very low temperature, I will open this and I will wrap them with a blanket, and the blanket has these beads that will start to warm up, and they'll slowly bring up the core temperature up. What you don't want to do, you don't want to rewarm them so quickly. And then another danger people do, if you know you're not going to get to a place of safety, don't try to rewarm them with, maybe, for example, if you only have like one coffee or whatever, and you know after that coffee you have another 12 hours of not having anything warm, you rather not give them, because you warm them and then you don't have anything to continue warming them. So you want to know that once you start warming them, it's a progressive process, as opposed to you warm them, then you go down. That is even worse than not even warming them in the first place.
Hey,
Okay.
Tirus,
Yes, sir.
I heard you saying about IOIV. So can you translate that in a layman's language?
Right. Okay. Let me show you. I think I have this a kit with me here. So again, like I said, this is probably just a quick refresher for people who are medics in the house. So IV is when you put a cannula and you give a cannula, and this is a giving set. So this will be a giving set, and to go with this, there will be a cannula. So you put a line in through a vein. So that is called IV, intravenous or intraosseous. So this is when you drill. This is a body drill behavior, no? So you drill through a bone because you want to give whatever fluid you want to give them through the bone marrow. So the only three places you normally do. Maybe four. Three of them when you do the IO with this is on the tibia plateau. You want to do on the head of femur, on the area crest. That's when you use that. If you're going for IO fast, so this one you normally do that on the sternum here, because obviously you can give blood, you can give fluid through the sternum. So, and this is quite painful as well. I've used it in the past, but not on me, but on somebody, and it's very, very painful. Again, you open it, it will have a template, and it shows you where to place it, and it's like a gun. That gun, I don't know if anyone can see that. That's a preloaded gun with needle. So once you set it and you align it where you need to do, you just press it, and you release the gun, or a cannula that looks like a gun, and it will go through the sternum already, and it will give you access through there. So that's why I said about IV. IV will be maybe through the ICF, the ICF, or when you're doing the IO, you go through the head of femur, tibia plateau, or area crest. Okay.
Okay. So do you have any guidelines with your side for you to start an IO? What are the guidelines?
Okay. Yeah. So what we normally the guideline we normally go with here in UK. If you do 2 attempts on IV and 2 failed attempts, so you try that arm, it doesn't go through. You try that arm, it hasn't gone through. You can go through IO straight away. Or if they don't have any veins, or for example, if their veins they've bled so much and they've collapsed. If you can't see any vein, you can go through IO as well straight away. We normally have a slight variation for that when it comes to the military, because once you go on the ground, it's you with the patient, and you need to save this patient. So you can even go through IO straight away. Because again, all you're trying to achieve, whether you go through IO or IV, is just trying to gain access and replace the fluids that the patient has lost. And again, this depends on what you're comfortable with. I know a lot of people, especially who are in the army, they are probably more comfortable, and this is funny, they are probably more comfortable using IO or intraosseous either than an IV. Because obviously it's painful. You probably think it's a complicated process, but it's straightforward. And once you drill through somebody, you have access straight away.
Okay. Yeah, that's good.
But again, it depends on your skills.
Yeah, that's nice to know that ERC, European Research Council, and the American side, we have the same guidelines. We start IOs after every, if you have two unsuccessful attempts on IV. So that's good. Do you have anybody else with a question?
Yeah.
It's still a clarification from Amolo still. She's asking whether you give adrenaline when the patient is hypothermic.
No.
When the patient is hypothermic.
Yes.
You wait until they are over 30 degrees. Once the temperature goes above 30, then you can give, and it's 15
Yes.
milligrams. If I'm not wrong, it's 15 milligrams. Tyler,
So
do you?
it's when the core body temperature. So when the core body temperature is between 30 degrees and less than 35 degrees, administer IV or IO adrenaline, but double the interval time. Okay.
Wow, today's lesson is very interactive. I like it. So somebody
And
is
that's
asking.
what we want. We want people to come and
Yes.
we're educating each other.
Oh yeah.
Tell us, when you mean double the interval time, what do you mean? Is it if you are giving at 3 minutes, then you double, then within 6 minutes, you can give it twice? What do you mean by that?
Okay. So in a normal terms, especially for the medics who, or not just for medics, for when you administer adrenaline, you give adrenaline, especially if it's a shock breathing, you give it after the third shock. So once you give after the third shock, then the fourth shock you don't do anything. You give another one on the fifth shock. Normally this takes between 3 to 5 minutes. So you do the third, you miss the fourth, you give another one at the fifth. So when somebody's temperature when they are hypothermic, when their core body temperature is between 30 and 35, you want to miss the fifth one, and then you go to the seventh one. So there will be the third shock, you give adrenaline, you miss the fourth, you miss the fifth, you miss the sixth, and then you do another one on the seventh. So instead of after every other shock, you've gone after 1, 2, 3, 4. So you doubled the time. So it'll be, instead of 3 to 5 minutes, it will be 6 to 10 minutes, because you're kind of trying to prolong the time. Okay, Karis?
Okay, that's fine, yeah.
Another question from
Any more?
Town is asking, do we know what guidelines does Kenya operate under? Do we know what guidelines Kenya operate under?
I'm not quite sure on top of my head, but whichever guidelines they operate under, it shouldn't be far off from whatever I've just spoken about. The UK, the Research Council guidelines.
Yeah, also.
Because like you say, like you've seen whatever I was saying and whatever they do in America, we always guided by almost the same guidelines.
Yes, and
maybe worded differently, but almost the same guidelines.
Yeah, Red Cross and St. John's Ambulance, AAR, American Medical Rescue, all of them, they go under AHA, American Heart Association. So they should be following the same guidelines we are following them in the US. Because AHA is based in the US. So they should not be different. Everything should be word to word. Maybe the wording can be different, but the timing and the dosage should be the same.
Okay, continuation.
True.
A question which had been asked earlier. So basically, physiological effects of hypothermia progressively depresses the CNS and decreasing CNS metabolism. So the brain electrical activity becomes abnormal. Did you get that, Tirus?
So go ahead, sorry, I lost you there for a minute.
So it starts, so basically, physiological effects of hypothermia progressively depresses the CNS and decreasing
Central
CNS
nervous system.
metabolism. So the brain electrical activity becomes abnormal.
Well, yeah. I think whatever the person is trying to ask is, does that mean when someone has gone hypothermic, everything slows down? So the answer to that is, everything has a knock-on effect. So when your body slows down, when your body function has slowed down because the body temperature has gone down, everything is prolonged. And I gave a good example when I said when you put something in a freezer. So if you put a milk in a normal fridge, it will take maybe a shelf life of 5 days. Obviously, once you open it. The same milk, if you put it in a freezer, it takes longer. So everything is guided by everything is affected by the drop in the hello. Everything is affecting the drop in the core body temperature. So everything slows down.
Yeah, so if I can add on that, whatever Tirus has said, whoever asked that question, who asked that question, Gideon?
It's Amolo again.
Okay, Amolo. Yeah, so I think he's going a little bit ahead of us, but because that one we're going to cover it in circulation, but just to help him a little bit, yes, whatever Silas said is true. Everything slows down whenever you have hypothermia, because if he want to read ahead, he can read about what we call the triangle of death, or little triad, which is hypothermia, acidosis, and coagulopathy. So you can, if you read about it, you'll see how everything ties together into death. It's called the death triangle or little triad. So, and hypothermia is one of them. So you can die very quickly from hypothermia. It's body shutting down completely. And then everything in you start turning acidic. Then they compromises the platelets clotting. So even continue bleeding more, coagulopathy. So, but hey, don't miss the next class. You're gonna read about that.
The terms,
I think that's
the terms.
Tirus, go ahead.
Tirus, proceed.
Amala, is that you?
It's on you.
Yeah, I was just going to say whatever you just said there, because the triangle of death, everything is a knock-on effect. It's a triangle. So one side, if you think about the triangle, if you remove one side of the triangle, it collapses. So when the body temperature goes down, it affects the way the blood clots, or it slows down the clotting factors. And not just slowing the clotting factors, it kind of impairs them. So the body is unable to clot. So the more you are slowing down, and again, going down to hypothermia is not just because of cold. If you start bleeding and you're bleeding a lot, it means your body core temperature is dropping, because there's no enough blood to take the heat, the energy around the body. So the core body temperature starts to drop. So once you start bleeding and you're not stopping that bleeding, or the tap, I like to call it tap. If you don't stop the tap, it means the body, the volume you had in your body is decreasing. And decreasing the volume means you're decreasing that heating capacity. And that affects your clotting factors, because the clotting factors rely on the body to be warm to be in that good conducive environment. So when you start going down with hypothermia, that affects the way your body clots again, and you want your body to clot so that it can stop the tap. And then again, when you're losing a lot of blood and the body is working so hard, it's like when you're running and you haven't even taken enough salt. So your body starts working in an aerobic state. So you are working so hard, and the byproduct of an aerobic state is acid. So that's now leads to acidosis. Again, acidosis is like lactic acid. That's again, it's lethal to your body. So you can see how one thing is affecting the other. So you started bleeding, the temperature drops. Now, when the temperature dropped, it affected the way your body clots, the clotting factors, and then the clotting factors, because there's not enough circulating oxygen.
We lost him.
Yeah, sorry, I'm back. So, and I was saying, once you get to that level now of acidosis, and as the level goes high, and I don't know if you guys listened to what Mr. Wanyoike said, we almost got into that cycle. He was almost tripping in and out of that cycle. If he had lasted for another half an hour, we'll probably be talking of a different story, because once you get to that state, even the doctors and the hospitals, it's too late to save you, because they don't know where to start. Do we start warming the person, or do we start stopping the bleeding, or do we deal with the acid, the poison, or the acidity of the blood itself? It's very, very bad. I hope I've answered that. Is there more? I hope I've answered the question that was asked.
Yeah.
I think that's fine. I see Evans Ojode has raised his hand. Evans?
Yes. Hello.
Hi, Evans.
You can hear me? Hello.
Yeah, but you're coming broken and unreadable.
Oh, can you get me now, Jake?
Sorry?
Can you get me now, Jake? Can you get me now, Jake?
No, you are very broken.
Okay. What I wanted to say, somebody asked if the guidelines that are being used in Kenya, and as paramedics in Kenya, we are using the AHA, the most often like the SCLS and the BLS. Most people are using certified, our AHA accredited institutions like E+, like St. John's. So the guidelines are just the same as what we've just learned today. The guidelines are not different. They're the same guidelines. So the guidelines used in Kenya are the same guidelines that are used by the AHA, American Heart Association. That is it. The person that was asking in Kenya, I'm also in Kenya, and that's all the guidelines we are using. So I just wanted to make a clarification on that for the right person.
Thank you very much.
Outstanding. Yeah. So for Mr. Ojode, just to clarify what he said the guidelines used in Kenya, they are just as the same as for the European and the American, because they borrow them from AHA. So just to clarify, so we were right on that. So Mr. Tirus.
Yes, sir.
Yeah, you have been talking about hypothermia. So someone might ask, does it just necessarily mean is only those guys who stays in cold places that they can encounter hypothermia, or who is susceptible to hypothermia? You need to clarify that, because you can encounter hypothermia sunny outside.
Yes, I would say anybody. If you think about that thyroid of death, the one we just spoken about, hypothermia, you can go hypothermic if you are losing a lot of blood and you are losing that heating capability. Your body is not keeping itself warm. So again, I'll go back to Wanyoike because he's a good case, and he's happy for us to talk about him. When I met him, obviously during the incident, for those people who are not here in the last Zoom we had, one of our ambassadors of this program, he's here because of help that we afforded him, and because of the initiative we are doing on the first aid at work. So to cut the story short, he was involved in an accident, and I found him when he was bleeding. along the bypass near Kihunguro area. He's a medic, or he's a KDF person who he knew a bit about using a tourniquet, stopping the bleeding, but because he was in so much pain, he could not do it himself. So he was trying to ask people to do it, but they could not understand what he was saying, and they obviously, because they've never done it. When I got him, he was actually cold to touch. Yes, I'm back. Yes, he had his warm jacket on. He had well covered. It was warm, it was sunny, but he was cold to touch. So again, I didn't have the thermometer to measure it, but I can tell you his core body temperature was less than 35. So it's not just us, or it's not just people who live in those cold countries. Even in Kenya, even in Masai. Even those hot semi-arid areas, people can go down quickly on to hypothermia. So to answer the question, yes, everyone and anyone is susceptible to hypothermia.
Yes, for the guys to understand what you're talking about, Mr. Wanyoike, yeah, I have a video here to show what he has did, and we have all the permission to use him because he's our program ambassador. So let me see if I can share that video, so at least you can see how basic life-saving techniques can save a life. He had lost a lot of blood, and I was very impressed when I saw what Mr. Tirus did on the ground. So let me see if I can share that video, so at least you guys can understand how you can be hypothermic, even if you be outside there in the sun. Yes, so let me try to share that video here. So can you guys see it? Tirus, can you guys see it?
Yeah, we can see it. We are seeing it.
Okay. Okay, you guys, you can see what he did.
Let's tell us.
Yeah, you can see how much blood he had lost in a very few minutes.
Too much blood. Yeah.
So Mr. Wanyoike has he lives here. Mr. Wanyoike lives to tell the tale, and that's why we are very passionate when you are giving this lesson, because we know they safe.
Yeah, so one thing that I'm so happy about in that video is how Mr. Tirus was very calm, because he was confident in himself, because he believed in the training that he had gone all over these years. He believed himself, he had confidence in himself, and he was assuring Mr. Wanyoike what he was doing. If you can look at Tirus, he was just chewing his gum, doing his thing. So he was very calm. So, and that's why we have decided to do this training. And so at least you too, you can be in the same situation and you can save a life somewhere. So that's our main aim and objective of this training.
See, as ambulance to be called, yeah, okay. Very calm, I like it.
Yeah. So do you have any contribution? All right, Tirus, do you have any closing remarks?
Second?
Do you have any closing remarks?
Oh, the only thing maybe I forgot to mention was you spoke about the advanced airway, didn't you?
Yes, we spoke about advanced airway last week.
Yes. So that is what we normally carry. It's an emergency surgical cricothyroid kit. So if you can see there, if I came to you and you have airway compromise, and maybe you have a blockage, I can actually get access through the cricothyroid membrane. So that's a full complete kit.
Okay.
Also, Jake, I think it's worth mentioning that the medics among ourselves, we highly encourage them to be part of this program. Like we said, it's a free first aid training. And if you feel like you have any input, bring it on. We want the more we can get from normal people, the more we can get from people out there, the better.
Yeah. So, to add on that, is very, very important for you to identify with yourself with our ground team. We have our ground team led by Mrs. Mary Dongo and Gideon Makomi. So it's very, very important for you to identify yourself with them, because once the borders open and once they open the airspace, we're gonna be coming to Kenya to launch some projects. And guess who we'll be looking for? We'll be looking for people like you, like you, because you're already trained. So please give your names and numbers and emails to our ground team, because once the airspace opens, we'll be coming down there to launch a few projects. And instead of us going knocking doors to people that we don't know, we already gonna be tapping to the already trained pool, and that trained pool will be you. Yeah, so whatever we are doing is gonna continue, and that's why, and we're gonna get to a point that where we're gonna start identifying some people who we can work with, because this is gonna be a continued process. This is gonna be a continued process in Kenya. We wanna see how we can do a few things down there to make sure that the patient care, we are bridging that gap, because right now there's that big gap in Kenya between the scene, or what we call the X, to the hospital. A lot of patients are dying in between there. A lot of patients in Kenya die in between that gap, from the X, or from the scene of accident, from the scene of fire, from the scene of stabbing, from the gunshot wound, from the terrorist scene, up to when they get to the hospital. That's where we are coming in to bridge that gap, because it's huge. It's huge. I was there last year with Tirus, and we can tell you, we saw a very huge gap, and that's why we have started this program. And we're gonna be using you people because you're already trained to bridge that gap. So whatever we'll be doing in the near future, once the airspace opens, we're gonna be using you guys. So it's very, very important to be consistent in this training, because you don't wanna come and start back to square one training people. You'll be already trained. So that's my 2 cents of advice. So Gideon, do you have anything to say in that regard?
Gideon, yes, please.
Gideon.
Hello?
Yes.
Yeah, what do you have to say in that regard? So these guys, they have to contact you with Mary Dongo, Joe, and the other team on the ground, right?
Yes. So what I've been doing as we go on with the trainings, I've been sending the links to our WhatsApp chat, and Hello? I'm
Hello,
saying,
we can hear you.
what I've
Yeah.
been doing is sharing a link to our WhatsApp platform where we are sharing updates, and as much as possible, share with us information about yourself, what you do, where you're joining us from, because we are building a database. Like Jex has said, we're looking forward to doing more as time goes. And it's from that database that we'll be able to know who we can work on, who we can work with on what. So it's not in vain that I keep on asking guys to share their details. We look forward to even greater things together. So yes, and I'm comfortable sharing my contacts. I'll post my number on the chat, so you can WhatsApp me, WhatsApp tafadhali. Then we can always keep connecting. Thank you very much, Jex. And thank you, Tirus, for that important lesson.
Is Mrs. Mary Dong around? That is, she can introduce herself too.
I don't see her. I think we lost her somewhere along the way.
Okay.
But,
Okay.
yeah.
Okay. So for you guys in Kenya, if you get in touch with Mr. Gideon Makomi, he'll take your information. Big things are coming. Yeah, we are just whatever. Corona is just barricading us to get there. But once everything opens up, we will be down on the ground doing great work for Kenya. So, and we want to work with you guys. That's why we started this program. Tirus, do you have anything to say in that regard too?
Yes, just to add on whatever you guys have said, I'm coming to Kenya in December. I've actually bought my ticket.
Internet.
We lost you, Tirus.
Tirus. No, we lost him. I think he'll be back shortly. Yeah, so as he comes back in, do you have anybody with contribution?
There's a question, Jex.
Okay.
I sent directly to you and Tirus.
Mm-hmm.
You should have a look.
Okay, so is it a question?
The comes there. Can you hear me? Yes.
We lost you from the word ticket.
Yeah. I was saying I bought tickets for December, so I'll be coming there, and I think together with the team we'll be rolling out a symposium.
Yes.
So like
yes,
like Makomi was saying, like Gideon was saying, we need to identify where these people are, and we'll be taking this training to them. So
okay, that's it.
Great, looking forward to your visit, Tirus.
hello.
Tirus.
I think I'm just getting. So I'm going through my phone. I'm getting so many people calling me after this. So I'm just going to end it there. And thank you very much for listening and for your time. And I'm very grateful to be part of this.
Okay. Yeah, do you have any other question or contribution before we call it a day or a night? Okay. Thank you so much. What's up?
Please check I've messaged you 2 questions inbox.
Inbox.
No, sorry, privately. Yes. It's from one of the participants sent to me directly.
Okay, the guy who is asking about the ECMO?
Yes.
The roaming strategy of choice for hypothermia, cardiac arrest. considered if feasible. How many hours? How many hours? So let me push it to Tirus, are you there? Hey, Tirus. So for Mr. Amolo, he's asking about the ECMO. Yeah, so I'm gonna say, let's do this. For extracorporeal, that's too much for this training. Extracorporeal membrane oxygenation. Yeah, so let me, give me his number so I can contact him privately, because I think that we're gonna be going so deep for that, for ECMO. Gideon.
Yes, Jakes.
Yeah, so give me his number so at least I can give him some reference materials on
All
that.
right, that's
yeah, because
fine.
that's going to be for everybody. That's going to be too deep and too much.
All right, that's fine.
Yeah, if we start talking about extracorporeal membrane oxygenation, that's too much. Yeah, let me deal with him one-on-one. Okay, so that's it for today. If nobody has any other question or any contribution, tuonane next Jumatano. Ni Jumatano. See you next Wednesday. Next Wednesday gonna be mute all.
Thank you, Jakes.
Okay, so as I was saying, see you next Wednesday. Next class gonna be saturation. So at least we can go building one on top of the other. So we started with that much hemorrhage, airway, respirations, saturation, and then the last one gonna be head and neck injury, then hypothermia. So, but for today, thank you so much, and thank you for being consistent with us. Thank you for participating in this training. So as I said, just send your name and number to Mr. Gideon, so at least we can maintain that database. So we can contact you when we get on ground very soon. Thank you so much, and may God bless you and your families.
God bless you too. Thank you very much.
Thank you.
All right, thank you.
Neighbors quarreled. Little girl fatally stabbed the whole two students 2 times in the chest. The story is produced by our very own Ben Hurley.
The mother of the 15-year-old minor is yet to come to terms with the afternoon incident in Nanaka area. The news that her daughter after the people have committed a murder, causing distress for a woman who at that time was unaware of her daughter's whereabouts. Neighbors say they had screams from the house.
Good to see you, Amolo. Finally.
Tumwambia baki ajibiwe tu na Jakes.